So next we have the pleasure of having Dr. Tom LaVeist, Chair and Professor of Health Policy and Management right here at GW at the Milken Institute of Public Health. Tom, thanks for spending some time with us today. Appreciate it. I know you're a busy guy. How are you?
I am. Usually I like to move around, but I'm so exhausted I think I'll just hold on to this. Let me give you a glass of water. Hi, good afternoon, everyone. No, I need some energy. I better stand up. I'll be on Amtrak soon enough. Okay. So, good afternoon, and thank you for inviting me here to address this. This is a consensus panel, is that right? Oh, wow, so you guys can actually make recommendations. So, unfortunately, I didn't know that before I put my presentation together. I wish I knew that. So I'll have to think of some things to, I have to think of what I want to make, what I want to put out there for you guys. Anyway, so I was asked to come here and address health disparities and didn't really honestly know exactly where this committee was going. And hastily added a few things to my presentation that I want to, so I'm going to try to speed talk my way through what I have, because as usual, I have more that I want to say than I have time to say. But I'm happy to address any clarifications necessary when we get into the Q&A portion of the presentation. So I'd like you to stop for a moment, if you will, and imagine this society without health disparities. What would it take to get there? What would have to happen? To a large extent, that's what this committee is about, right? Imagining that we can get to that place. For most people, awareness of health disparities comes in 2002 with the publication of Unnatural Causes, right? And, I'm sorry, Unequal Treatment. And that was Unnatural Causes also, Unequal Treatment. And over the years, we've done a lot. We've thrown a lot of stuff on the wall to see what'll stick, trying to address the problem. But I've said ever since 2002, and I'll say it again, that much of what we are doing about health disparities will fail. And it will fail, I think, because we haven't stopped sufficiently to take account of the diagnosis. It's almost as if you walk into the waiting room in a hospital and just start handing out pills to patients. Now, there's a good chance that you will randomly give the right pill to the right patient, right? But the odds of getting it right are much greater if we first stop and say, okay, what is the real driver, or what are the drivers? So when I talk to most people about this issue, I get three answers. Now, I'm sure this group is more enlightened, but basically it comes down to, well, if we could just equalize access to health care, the problem goes away, or that there are really some biological genetic differences, those it was commanded by God, that there shall be disparities by race and ethnicity and socioeconomic status, and that's just the way it is, or that it's not really race, it's socioeconomic status, and that is really an insidious myth, that one, that it's not really race or socioeconomic status. So I want to make a few comments about each of these myths, just to make sure that we've addressed them, and then move on to what I think are the drivers, and some thoughts about how we move forward. So first, let me address the equal access to healthcare issue. So this is a chart from a study that was led by some guy named LaVeist a few years ago, where what we did was we went to 3 hospitals in Baltimore, and this was before the electronic medical records. So we actually went to the paper records in the basement of the hospital, and we abstracted 10,000 medical records to identify patients that were American College of Cardiology Class 1 for referral for coronary angiography, right? So every patient represented on this chart should have been referred for catheterization. So these were all patients that were Class 1. They were appropriate candidates. They were all being seen at a hospital that had a cath lab, so they had the ability to provide the service, And this is not a healthcare access problem because we eliminated patients that did not have insurance that would have covered it. So this is only patients that were insured and had insurance that would have paid for the procedure, that was medically indicated, and was being seen at a hospital that had the ability to provide the service. We're talking about only, we took only insurances that would have covered it, right? So this is what we're talking about. The goal was to take the access issue off the table and say only among those who were able to pay. Another interesting study that I like to use, this was from the VA hospital in Pittsburgh, where they're looking at revascularization, and of course these are all VA patients, so there should be some equality in terms of availability of the procedure. And you see two interesting things here. So first of all, 100% of these patients should have been referred for revascularization, and only 50% of the white patients are referred, but half again of the black patients are referred. So we have a general quality problem, which I think we've all recognized, but also there's a disparity in quality. And these two studies I like to use as examples of the counterfactual. If we created universal access to health care, and we only looked at people who actually did take advantage of that access, we see that we still find the disparity. So there's something going on here that's more than just access to health care. I once asked an audience that was where this issue came up. I said, if we were to take, I was in Memphis, and I asked them, I said, okay, if we took the zip code in this city with the worst health statistics, whichever zip code that is, and we built the brand new, shiniest, fanciest hospital ever produced in the history of hospitals, right? And we gave everyone living in that zip code equal and free and unfettered access to the hospital, would that eliminate the health inequalities problem? And that's until you really think it through and you realize that no, it wouldn't, because the health inequalities problems is not produced by hospitals. It certainly is a part. This is not to suggest that healthcare has no role in addressing health inequalities. It certainly does, but to suggest that we're going to find a solution to this in the doctor's black bag, where there's no pill or potion to address this issue. The next one is this issue of genetic or biological differences. And I'll try to go through this really quickly because I'm assuming that this audience by now is past the belief that there is some gene that causes cancer and heart disease and stroke and depression and schizophrenia and homicide and HIV and also makes you black. And I assume that this audience is past that. But the point here, and I think the point here is the same point for all three of these myths, is that it's not the direct, obviously illogical statement that I just made about genetics. It's the insidious way that this type of thinking creeps into our thought process, and the narrative is there even when it's unspoken. So, how many of you here are not familiar with this drug, Bidil? Okay, so I'm going to have to give a quick Bidil. So for those of you that know about Bidil, forgive me for the Reader's Digest condensed version of the story, but I'm going to speed through this because it's a really fascinating case, and there's an article published in Health Affairs a few years ago that I thought was really excellent and summarized this complex situation. So Bidil is a drug that really evolved out of the 1970s. In the 1970s, new classes of drugs were coming onto the market: calcium channel blockers, beta blockers, drugs that are commonplace now. And some physicians discovered that if you combined these new drugs with two very inexpensive generic drugs, that patients were having a really good outcome, right? So they said, let's do a clinical trial and see if we can document that what we think we're seeing, we're actually seeing. And they do a clinical trial, and they publish it in the New England Journal of Medicine, and it shows extremely good results. So this is great. We've got this new combination therapy to address cardiovascular disease. And if it had stopped there, it'd be a great story, but it didn't stop. What they then said was, what if we put these two generic drugs together in one pill, got a patent on that, then there would be a economic windfall. So they do that. And then they're ready to come to market with this drug, and then FDA says you can't go to market with the drug because the study you did that you published in the New England Journal was not done to FDA standards. You have to do a new trial. So obviously, we all know that if they are going to organize a new clinical trial, by the time they get that trial done, the drug will be off patent and there'll be no economic windfall. So what do? They do what any red-blooded American researcher would do. They went and did a little data mining, and they went back to that data set, and they found that the drug or the therapy was more effective in black patients. Now, I use that terminology intentionally. Drug more effective in black patients. Now, what does that mean? So let's say we had this is a hypothetical. Let's say we had 100 patients that were African American and 100 patients that are white. I'm going to just use two groups to keep it simple. And they have the same diagnosis. And just so you know, this is not a trick question. They were all diagnosed by the same person on the same day using the same exact methodology, okay? So this is not a trick question. This is an actual question. And we give all 200 patients Bidil, or the drug, right? And our results are 75% of the black patients benefited and 65% of the white patients benefited. Now, in the real world, we'd be really happy with those numbers, we all know. But those are our results. So that 10 percentage point difference would most assuredly be statistically significant. You with me? You out there? Okay, thank you. Told you I'm exhausted, right? So just give me a little energy here. So that 10 percentage point difference would certainly be significant. Is it accurate to say that their drug is more effective in black patients? So that was not a rhetorical question, that's an actual question. Who says the drug is more effective in black patients? Okay, who says it's not more effective in black patients? Who's afraid to answer because you think it's a trick question? 90% of you. It's not a trick question, it really isn't. I get this all the time. Well, the answer is, of course, that does not indicate that the drug is more effective in black patients. If you're part of the 75% of black patients that benefited, you benefited. If you're part of the 65% of white patients that benefited, you benefited. It either worked or it didn't work. So you can say it's effective for more black patients. It was effective in a larger percentage of black patients. That would be accurate. But it is not more effective for black patients. Okay. So they go back and they do the data mining, and they have results somewhat like the example that I gave you. And they publish an article in a little-known journal this time, and they say the drug is more effective in black patients. So they go out and get a new patent, this time for use only in black patients. And in 2005, not 1905, 2005, the first drug for use in only one race group is approved. Bidil. Okay? Then they go and they do a new trial. This time they do a trial in only self-identified black patients. And what do you think they found in that study? That the drug was effective. Why? Because everything we know about the drug tells us that it's an effective drug. If it had been an all Eskimo sample, it would have been effective. It doesn't matter. We know the drug is a good drug, right? Everything we know about it tells us that. So now we have this drug that is only available, or should only be available, for use in one group, African Americans. So you're in your treatment room, and a patient comes in, and you've got to decide whether or not you should prescribe Bidil. So to whom do you prescribe Bidil? Do you prescribe it to this African American gentleman who has 2 grandparents from Scotland, 2 grandparents from Jamaica, and is born in the Bronx? Do you prescribe it to this African American gentleman with 2 Kenyan grandparents and 2 white American grandparents? Do you prescribe it to this African American gentleman who's got 1 grandparent from China, 1 grandparent from Thailand who also has a Chinese ancestry, 1 white American grandparent who also has Native American ancestry, or 1 black American grandparent who has Native American and white American ancestry? From whom did Tiger Woods inherit his Bidil receptor? And how do you know? By simply asking him his race. And does he know? Because ultimately, that's how you get race in your data system, right? Either you ask the patient, or you look at the patient and you check a box. By the way, should we give it to this guy? Because he looks like a black guy to me, right? But of course, this is Vijay Singh, who is from Fiji, and he is not an African American at all. And hopefully VJ will never need Baidu, but since we know Baidu is an effective drug, hopefully if he ever does, that drug would be made available to him. So here, 2 years after the Human Genome Project proved that there was no meaningful biological or genetic differences between race groups, we get the approval of the first drug for use in only one race group. It is insidious the way these three myths affect our thinking, and that in turn affects the way that we intervene around health disparities. The last one is this income thing. So I'm going to, hopefully this can be put to rest quickly. I just put together some charts here looking at race differences and a variety of outcomes at different levels here of education. I could go on for hours with this and I won't, but it doesn't really matter much what the outcome is. The pattern is pretty much the same. There are differences by race regardless of income level. Most of the time when we start talking about disparities, we quickly segue into talking about poor, low-income communities, and we assume that this is really just a matter of poverty. This is one of the most insidious ways as well, that sort of thinking affects that narrative affects our thinking. So I did want to quickly point this one out. This is actually a very new finding that we are going to publish. This one is we had to pull together 8 years of data from the MEPS in order to get a large enough number of people with incomes over 175. Most national data sets only collect income up to 75,000, and they categorize everyone above 75,000, but MEPS asks income in much higher income categories. So, and what we find here is that unlike virtually every other outcome that we know, for African Americans, the risk of hypertension actually increases as income increases. So when you get to the very high income levels, you actually have the highest risk of hypertension. I think this raises a lot of really interesting questions that we don't have time to get into here, but maybe during the Q&A we can talk about some of that. So there's a lot more complexity to this. Now, when I show these slides, I'm sure, in an audience like this, there's a number of aficionados in the room who say, well, we deal with this interaction between race and income by using regression analysis. So I'm going to quickly address that one so we don't have to talk about that during the Q&A. Okay, so I'm going to do an analysis for you straight out of biostatistics 10, I guess this would be 102, right? Where we use the methods that we're taught to use to address this issue of interaction between race, accounting for socioeconomic status and looking at race differences. So the example I'm going to use from the Health Interview Survey, I'm going to use all the adults over age 40, and I'm going to do a really simple analysis looking at a dependent variable will be activities of daily living, or ADLs, and we're only going to look at having one ADL limitation. So I'm trying to set the bar very low, right? So you just have one ADL limitation, and that's the dependent variable. It's not very disabled. So there's 4,400 African Americans in the sample, and these are the income categories and the sample sizes. So as you can see, these sample sizes and cell sizes are larger than most of the studies that we see published. So I'm trying to, again, make it clear that I'm not trying to game this outcome. So what we're taught to do in our classes is to first look at the bivariate relationship, right? So here I'm looking at race as a binary variable, black, white, and looking at one ADL limitation, and we see an odds ratio of 1.46. Confidence interval says that this is significant, and that means that African Americans have 46% greater odds of having at least one ADL limitation. All right, am I right? Am I doing okay? So I'm passing biostats, okay. That's the midterm. Then we look at the relationship between income and ADL limitation, and here we see the odds ratio is decreasing as income levels increase. Odds ratio, again, says that this is significant. So this is, again, what we would expect to find, right? So now we move on to biostats 102, and we put income and race together and see what happens. So interestingly, we see that the income relationship is pretty much the same. As income increases, the odds of ADL limitation decreases. But look at what happens to the race effect. Not significant. So what do we do now? Okay, I'll answer. I don't have time to wait for your answer. So what we'll do is we will publish the article, right? And we'll get an article published, and we'll get promoted, and we'll get a raise, a merit increase, and all is right with the world, except that we have now added false information to the research literature. Because if you simply array the data by income and race groups and look within cells, we see a couple of interesting things. One thing that we notice is that in the lowest income category of $20,000, there is, in fact, a significant race difference. And the other thing we'll notice, which is the bigger problem, is that in the income category of $75,000 or more for African Americans, that rate is only being calculated on the basis of 8 events. So that means in the National Health Interview Survey, the biggest, most official data set that we have, the official record of the health of the US population, there are only 8 African Americans with incomes over 75 that have at least one ADL limitation. Do you feel comfortable and confident calculating a rate on the basis of 8 events? Your answer is no. Trust me, your answer should be no. And do you feel comfortable setting national policy on the basis of this rate? Yet we do it every day. Now, for the statisticians in the room, I will also point out that the model, and for the non-statisticians, just bear with me for a moment while I get a little technical here. I will point out that that model, that analysis, was greatly underspecified. Now, everything that we would do to make that a fully specified model would require an even larger sample, right? So how many papers have been published with much more complex analysis on smaller samples, right? So I should say right now, so if you go to PubMed and you punch my name in, you will find that I have committed some of the same sins. So this is not about, this is not he who is without sin should cast the first stone, but rather you should repent, go forward, and sin no more, okay? So this is the complexity that we must deal with when we do health disparities research, and why I say that much of what we think we know about health disparities, we don't really know because the research is so complex to do really well. So if it's not genetics or healthcare or socioeconomic status, then what is it? And I think this may resonate particularly well with this committee. This is a map of the United States that was produced at the University of Virginia from the 2010 census. They placed a dot on the map representing every American, and it's color-coded by race. So blue was white Americans, Black African Americans are green, Asians represented in red, and Hispanics represented in orange. And that's hard to see, so I'll show you. This is New York City, and I'm picking New York City because it's my hometown. And New York City is a true rainbow. But notice the clear demarcation of the different colors, right? You can see where one color ends and the other color begins, which tells us this is the boundary of this ethnic group's neighborhood versus that ethnic group's neighborhood. This is interesting here. I can point this out. If you can see that there, see that white rectangle? That's Central Park. So now, before going to graduate school, I was a social worker back in the 80s in Manhattan, working with homeless populations. So Central Park is in white because no one lives in Central Park, at least officially. But I can assure you, as someone whose job it used to be to go into Central Park and deal with homeless populations, that there are plenty of people living in Central Park. And many of the colors of this rainbow should be there. So I've circled Brooklyn because people from Brooklyn believe Brooklyn is the center of the universe. And of course it is. And this mass of green here is Brownsville, East New York, which is the neighborhood that I grew up in, if you know Brooklyn. This segregation facilitates differential exposure to health risks. Also, differential availability of community resources that are protective. And it maps very nicely, nicely being an interesting term to use, very nicely with the distribution of disease and early death. Segregation is a primary structural driver that facilitates differential environmental exposures, differential food environments and levels of food security, and helps to produce disparities. And rarely do we account for this in the research that we do or in the way that we think about how we address disparities. Typically, we turn to individual level interventions. I know that this community is dealing with community interventions, which I think is appropriate, but typically it's about individual level interventions. So since what we have been doing for years is taking these national statistics, national studies like Health Interview Survey, and we produce these reports, and we see race differences, and we don't stop to ask ourselves, to what extent are these race differences driven by the fact that while we all live in the country together, we experience the country very differently based on our geography. And that geography maps with race and social class. So we got the idea, what if we could identify communities that were racially integrated and where there weren't differences in race and socioeconomic status? Would we still find the same disparities? So we went out to identify census tracts that met the criteria of having 35% African American, at least 35% African American and 35% white living in the same census tract, and where the median income and high school graduation rates were roughly equal, and said, can we identify communities like this around the country? We identified those census tracts, went into 2 of them that happened to be contiguous census tracts in Baltimore City, and we replicated portions of the protocol from Health Interview Survey and NHANES and asked the question, what is the nature of race disparities when people are living in equal conditions? Do we still find the same disparities? So just a quick profile. This is from the census. There's 2 census tracts of 44% African American, 51% white. Median income is very low, but also equal, as you can see, very equal. Poverty rates are also high, and again, roughly equal. Levels of education also very similar. And finally, distribution of gender, sex is also similar. So this is about as close to laboratory conditions as you're going to find in a naturally occurring environment. So the study is 2 census tracts. There were 40-minute interviews. They were conducted at the doorstep or inside the home in most cases. Blood pressure was one of our primary outcomes. And we succeeded at interviewing 42% of the adults living in those 2 census tracts. We didn't sample. We went for the entire population. If we had time, I'd get into why. But we can talk about that after the session if you really care to get into all of that. But 42% over 13 weeks. And I can tell you how we pulled that off, too. I'm pretty impressed by that, frankly, personally. Very happy about it. So first, I'll just give you some background, and this is comparing our sample to the census, what the census found. And I think we did a fairly good job of representing the community. This is the favorite slide I've ever produced in my career. So either they lied to the census, remembered the lie, and told us the same lie, or I think we did a fairly good job of representing the community. Here we see some differences here that we'll have to account for in the analysis. Distribution of sex. So what we did is we go into health interviews. We went into the literature. We identified a paper that was published using Health Interview Survey or NHANES or MEPS. Then we replicated the exact analysis in the federal data set, and then did the same analysis again in our data set, right? So that's what we're doing, and we want to compare our results versus the results we get when we use that model in the federal data set. So here, I'll just give you an example. This is from hypertension. We had 4 different models that we pulled out of different papers that were published. We replicated those papers in NHANES, and then we did that same analysis. And remember, we collected all the variables using their protocol, so we collected the same way they did. And what you see in each case is that we find a smaller disparity. We still do find a significant race difference, but in each case, that difference is smaller when people are living under similar conditions. Okay, so typically what we teach in our classes is that African Americans have about double the odds of hypertension, and as you look at the national sample, that's what you're finding. In our sample, we find that we still do find a significant race difference, but that difference is significantly smaller. But look at what happens, and as I showed you earlier, hypertension is an interesting special case, right? When we look at some other outcomes, what we actually find for diabetes, in the national sample, we find African Americans having 61% greater odds of being diabetic. In the sample that is racially integrated, we find no race differences in diabetes. For obesity, this is obesity only among women, African American women, 87% greater odds of being obese compared to white women nationally. In our community that we studied, no significant race difference in obesity among women. The hypertension result I shared with you earlier, and use of health services, again, we see essentially no significant differences, but it is just instructive that the direction of the relationship changes in our community. I'm not entirely sure what that means. So when I ask you to imagine what would need to happen for us to have a society without health disparities, some of you may have had one of those myths into your brain. Well, if we can equalize income levels, or if we can just make healthcare access available to everyone, or if we could do something about this to find maybe there's some precision medicine or something we can do to address this genetic difference, you know. But in reality, it has much more to do with the cultural environment that we created as humans. It's the human-made environment that produces the disparities. So one of the projects that I'm working on after years of dealing with this health disparities problem, and only to find out that in a survey published in Health Affairs about 2 years ago showed that there's, over the last 20 years, virtually no change in awareness in the general population of health disparities. And it's just not even aware that there is an issue. And so in spite of all that we've been doing in the last 30 years, the general population is not any more aware than they were 30 years ago. And so I'm working on a documentary film with some filmmakers, and part of what that's been about is trying to figure out how do you message around this complex issue in a way that's meaningful to people in communities and that people can use, and also to highlight some examples of people that are making a difference. And the film is called The Skin You're In, that we're working on. Follow us on Twitter and Facebook. So, some of the things that we're going to talk about. This is a community, Newport News, Virginia. This was one of the oldest black communities in Virginia, and it is sandwiched between the James River, Chesapeake Bay. This is the major interstate going off the peninsula and into a tunnel. This is the community, and this is a coal depot. Mounds of coal. Now imagine the crosswinds across the James River, blown across the community, extremely high rates of respiratory disease, asthma, premature death. We also have the hazard of the highway, which is in and of itself an environmental hazard, and a tunnel. So the fumes in the tunnel must come out, and where do they go when they come out? Back out into this community. This community is also a classic food desert, and I see Bob Boulder's here. Unfortunately, I wasn't here to hear his talk, but I would imagine he's covered much of the same ground that I'm covering here with this issue. But there are communities like this all over this country. Newport News, I think, is just a glaring example of it. One of the things that we also want to do is to talk about community interventions, and by this, we're talking about individuals, how individuals, in some cases, people with virtually no resources, are able to do things that make a difference. And this gentleman here is from an organization in central Brooklyn called Man Up. And his organization is a group that you don't want to be a part of. To be a member of this group, you had to have survived a gunshot. And what they do now is they try to stem the continuation of violence. They work together with the hospital there, Kings County Hospital and Brookdale Hospital. And whenever there's a report of an ambulance bringing a gunshot victim to the emergency department, they contact this organization, and in a rapid response way, they send one of their members to the hospital to begin to counsel the family members and friends of the victim to try to reduce the likelihood of retaliation and to try to reduce violence. This is Dr. Catherine Brown from Nashville, who goes into the communities in Nashville, knocking on doors. I went with her when we filmed her for the film. We went to a motorcycle club, teaching people to do CPR, because the studies have documented that people in Black, Latino, and low-income communities are much less likely to know CPR, so that when someone is in need of CPR, there's no one around that knows what to do, so we have people dying unnecessarily. She may have saved countless people. Again, an individual creates a community intervention and is making a difference by teaching people to do something. This is a barbershop in Brooklyn also. Again, they do health education. I'm sure you're all familiar with these types of interventions, so the health barbershop interventions. And this is Ron Finley in South Central Los Angeles. Ron Finley grew a food garden on a median strip out in front of his house because his neighborhood had a great high level of hunger, food insecurity, and there was a lack of availability of fruit and vegetables. And he said, you know what, I'm going to just plant a vegetable garden and give the fruit and vegetable out to people for free. So now he travels all over the world teaching people in poor communities how to grow food gardens. This is a group in Harlem called the Bartenders. These guys came out of prison where they got into physical fitness, doing jailhouse exercises, went back to Harlem, and wasn't able to get resources to stay physically fit. So they creatively figured out ways of utilizing things in the environment that they could use to do exercises. Now they have an organization that is throughout New York City public schools teaching kids their physical fitness and discipline. And finally, this is Pastor Michael Minor in Mississippi, who banned soul food from his church and lived to tell about it. and also lived to see reduction in weight among members of his church. Wow. And he's now working throughout the National Baptist Convention to teach pastors all over the country how to do what he did. So I wanted to point out these interventions in particular because these were interventions that were done by individuals. Some person said, you know what, I can do this, and maybe this will have an impact. None of them were necessarily, except maybe Catherine, were necessarily trained to do what they're doing. They didn't, Ron Finley didn't go out and get a grant to buy seeds. He just got some seeds and he put it in the ground and see what happened. And they were able to make a difference, or at least trying to make a difference in their communities through those interventions. Now, in some cases, they've now created organizations and they've gotten grants and they're doing all of those things, but it didn't necessarily take a top-down approach or an approach of having a foundation offer a big grant to an organization to make a difference. These are all people who are able to figure out ways to do that without that. Not suggesting that they don't want grants or resources, but suggesting that you can make a difference by utilizing the resources that you have at your disposal. So thank you very much. I'll stop there.